Excellent. Thank you all for joining us this afternoon for our second AHPBA webinar. Today, the focus is on reemerging and establishing a new normal for HPB surgery in this time of COVID-19. And we're extremely lucky today to be welcoming back several of our past presidents, many of whom hold leadership positions not only in national societies or relative to HPV, but also leaderships at their respective institutions and hospitals. And they will be sharing with us today their experiences around managing the crisis of COVID-19, not only their experience with the surge in each of their respective different locations and how they have been actively managing COVID-19 patients, but also beginning to focus on how we are establishing a new normal, what approaches are being used to prioritize cases that have previously been postponed, how are we contacting patients, what's a non-essential elective ambulatory surgery patient, how are we handling HPB procedures, and then what is the role of trainees as we begin to pivot into doing more non-essential and elective surgical procedures. So I just want to start off by setting the stage and establishing some context. All of you, I'm sure, are well aware of these numbers that are seen daily in different news media and on nightly broadcasts. And this essentially summarizes the data in the United States, where there's roughly 1.4 million total cases to date and over 80,000 deaths. This figure in the lower right-hand corner shows a number of cases relative to the days since the first case. And as you can see, in many other countries, it has been a significant plateauing of the cases. However, here in the United States, there has been a steep increase, which may be attributable both to the actual number of true cases, but then also the increased utilization of testing in the United States that has allowed us to identify patients who are COVID-19 positive. These are some data from the CDC, and I would draw your attention to this black line, which represents the number of positive patients overall. And again, these data show the number of specimens tested relative to the week. And as you can see, that there is some suggestion that the number of positive cases is beginning to plateau or perhaps somewhat decrease when you look at national data. And given this, there has been significant conversation and movement both at the state and national level to relax restrictions around social distancing, with the opening of salon, barbershops, restaurants, and further relaxing of social distancing in the community. All of this has shown increased light on how hospitals are responding to this new normal, and what is the role in particular in surgery of pivoting to doing not only essential cases, but beginning to do non-essential elective procedures, both in the ambulatory setting and perhaps in the near future, non-essential elective surgery in the inpatient setting. So today, we want to discuss with you and lean on the expertise of our past presidents to talk a little bit about the road to recovery. I do want to emphasize, however, that one size does not fit all. And we want to emphasize that the road to recovery may be fast, it may be slow, or it may be intermediate. And this clearly depends on local factors, geographic prevalence and incidence of COVID-19 in your specific location. It depends on the burden of COVID-19 patients in your local hospital. And it also depends on the amount of PPE that may be available to you in your hospital. So again, one size does not fit all, and this is a very nuanced discussion and decision that needs to be happening at the local level. The other pieces of data that I'd like to show you today are just some data relative to patients' opinions around the road to recovery. Well, we as surgeons and hospitals may be on the road to recovery at a certain speed. It's important to note that many of our patients have significant concerns about returning to the elective surgical procedure schedule. These are data, national data from 1,000 patients who were surveyed. And as you can see here, 89% of patients plan to reschedule their elective procedure. However, of note, only roughly 20% of patients, at least in this survey, suggested that they would like to have their surgery rescheduled either immediately or within 30 days of it being offered to them. And if you look at data stratified based on routine doctor's appointment, having an elective procedure in a hospital, or having an elective procedure in an ambulatory surgery center, you will see that the numbers are relatively consistent in that only about 25% of patients actually even want their elective operation, even if our facility is offering it. And this level of attrition needs to be taken into account when we are doing planning at the local level with regards to staffing our operating rooms. You can see here that even amongst households that have healthcare professionals relative to households that do not have healthcare professionals, the percentage of patients who are interested in having their surgery within 30 days in non-healthcare households is significantly lower. And I guess my point here is that, you know, patients have significant concerns around the safety of our hospitals, around the safety of having elective procedures at this time. And it is incumbent upon us as providers and caregivers to reassure our patients that our hospitals are safe and that they should be seeking the care that they need when appropriate. So with that as a backdrop, again, I'm extremely excited to have this very esteemed group of individuals with us today. And we're lucky that our first speaker is Dr. Mark Callery, who is professor of surgery at Harvard Medical School, where he's the chief of the Division of General Surgery at the Beth Israel Deaconess Hospital. And Dr. Callery was our president from 2008 to 2009. Mark?
Thank you, Tim, and good afternoon, everyone. I'm looking at my stopwatch, Tim, so you'll be happy to hear that.
All right.
When Tim asked me to participate on this, and I'm sorry that we can't get my video input to work, so it'll be name only, but the slides are more important. I thought the best thing to do for this would be to speak from our unfortunate situation here in the Northeast. And I'm going to frame that issue for you because, as he mentioned, not one size will fit all on this road. And if any one of those visuals, we're in that little blue buggy on the bottom right and will be for quite some time. Next slide, please. So as you can see, I entitled this Reclaim, Recover, and Reboot and Resume. And we are currently right at that junction, and I'll explain to you why. We have some general guidelines put forth by CMS. You've seen them, I'm sure. And now that we're in the heat of this battle, they are really general. To prioritize, we're all doing that. That doesn't start us off. To have non-COVID care zones, we don't have any. We would be recovering those. We would have sufficient resources. We don't know if we will or do. We should be continually evaluating areas of low risk of incidence, and I'm going to make a comment about this in a minute. Pretty much the only thing that's for sure about this is our need to be flexible. Flexible and patient, we recommend as we talk amongst each other about this whole project. Next slide. So we have some good news and we have some bad news. The good news is we have and we represent a worldwide group of talented, motivated HPB surgeons. The bad news is where they are going to get their work done is now and for quite some time will be under very critical constraints. These critical constraints can really be balanced across 5 bullets of facility, personnel and workforce, equipment and PPE, and then processes and protocols. And the image to the right obviously implies that getting going and recovering and resuming is going to be a very, very heavy lift, heavier than in some spots than others. And it's going to require a lot of imagination and innovation and ingenuity. Now, my comments are going to be framed on some troubling realities that we face here in the Northeast. And I'd like to frame those for you because thankfully our situation is not going to be reflective of what's happening for everyone. But it will prompt me to put forth a urge of caution for you. The first thing is that Massachusetts is the 15th ranked state in America in terms of population. Unfortunately, it is the 3rd ranked state of COVID deaths, just announced an hour and a half ago of 178 more today, bringing our total up over 5,300. New York State is number 1, unfortunately, at 5 or 6 times that, nearly 28,000 cases. New Jersey is nearly 10,000 cases. And you can understand that this is a local regional issue of a hotspot in the Northeast. Because of that, life has changed dramatically up here. Now, we did not have the obliterative surge that New York City metropolitan area and northern New Jersey and southwestern Connecticut suffered. And to some extent, here in Boston, we've been able to learn from their misfortune by knowing that every single resource needed to be devoted to avoid being overwhelmed as hospital systems across the Commonwealth of Massachusetts, and especially the greater Boston area. Our hospital has been lost to this pandemic. Every single pulse of our heartbeat is dedicated to fighting COVID, and every single resource on a daily basis has been invested in fighting COVID. This is our hospital based on a few pictures right here. If you look on the left picture, Tara Kent and I walked down that hall behind those blue drapes to welcome our patients in the pre-op holding area every day when we're operating. But you can see now it's all barriered off with insulation tape. Behind that is a 40-bed COVID ICU. The good news is it was reopened last night and is becoming cleansing today and is being recovered by the hospital. The middle panel depicts the bridges between the hospital building complexes where all the equipment has been shuttled in for safety of purpose and because there's just simply no room in all of the repurposed areas of the medical center, which is, for those of you who visited, is a sprawling medical center. And so there are no COVID negative zones across this process. We all like to stand in front of the OR front desk in the morning and look and see what's going on for the day, don't we? Well, here's a view from last week when I was getting ready to do a case. And you can see here that the top line says COVID rooms are 4, 10, 17, 18, and 15. The line below that says no anesthesia machines exist, and I think it was 11 rooms across that red line going across. And you can see here OR 4 cardiac, OR 10 orthopedics, OR 17 general surgery, OR 18 endovascular, OR 15 trauma and transplant are all completely off kilter and completely off limit because they're ready to be used only for COVID. So I show you this not to induce drama, but to clarify you the impact in a very high death rate, high hotspot zone and what it's done for our hospital. Next slide. And so here are our constraints. We don't have these elements of our hospital currently functionally ready to go. And so we are only at the earliest possible inflection point of thinking about and preparing for recovery, despite, as Tim mentioned, some flattening or early decrease in new case diagnoses, but still persisting high rates of death and a potential W configuration of the curve, which has everyone worried up here. We don't have efficient clinic spaces. They're not staffed. Waiting rooms, operating rooms, procedure suites. We don't have recovery areas except only for a few. On our main hospital campus, we have 10 OR PACU spaces that are also double used for recovery room spaces. Every ICU bed has been dedicated. We've functioned at nearly 164% of ICU capacity. But because it's all been planned for, thankfully, seeing the tough lessons they learned in Spain, Italy, and New York, Boston and certainly our hospital avoided being overwhelmed. But right now we are at a very common analogy that Richard White, one of our true leaders in this, puts forth, saying that unless you have some place to land the airplane, you cannot let the airplanes take off. And so We can bring in and check a patient in through the clinic and waiting room as they look like, but don't bring them in the operating room unless we have places to recover them, and that's where we're at. This is not even close to being at the point of resuming elective surgery, which for our division, we shut down on March 13th, and it's been shut down since, initially to April 20th, and now again out through April 23rd. Next slide. To deal with this, we have to look at everything, and we have multi-matrix groups now who are working on this, all different types of administrative allegiances. We work as part of a major health system in the Commonwealth as well. And for our clinic spaces, we're being asked as we go forward to come up with new manners by which we can repurpose, mix use, newly use, and redesign clinic spaces, which will simply not reflect what they used to be only 2 months ago. Our waiting rooms now are already being set up for distancing with chaperoning, checking patients in, drive-through oncology centers at our neighboring hospitals, and we have not allowed a visitor of any family member into the hospital in over 2 months, unfortunately. But all of these things now are coming together through an apex group of the Hospital Incident Command, which reports to the system, and down across groups in ambulatory, procedural, perioperative services. And then below this, despite hundreds of people across both the medical center and our department being furloughed with reduced staff, and the staff that does remain being redeployed all over the place, we have to somehow get the wheels in motion again. And it is going to be quite the task. Next slide. The next constraint is our workforce. Great workforce, amazing people we are proud of, as I'm sure you are at your hospitals. But these are physicians and nurses, APPs and technicians, absolutely everybody, a very high impact of administrative directors, both for the medical group and the hospital in terms of furloughs. The front desk staff, the environmental services, absolutely everyone who works at our hospital is impacted by this. And this is just at the physical plant of the hospital. This doesn't have anything to do with patients and family members who are suffering economic constraints at home, emotional distress, kids being educated, and unfortunately, family members who have succumbed are very ill from COVID-19. Next slide. The recovery is going to be under kind of a new type of buzzword. We have to assess all of our furloughed and redeployed staff. By redeploy, I mean taking the nurse who was in the intensive care unit and redeploying them in a med-surg COVID positive unit, perhaps. And then we have to, quote, unredeploy. Everything was wound up very, very tightly at our hospital in order to prevent being overwhelmed by this pandemic impact. We now need to unwind that, and it's going to take quite a bit of time. Some people have been activated up here into the National Guard. They're not available to work. I mentioned some of these other issues, and then it comes down to just general good health. Who is at risk to come into work? Who can work remotely and how? And then what are going to be new assignments for all of us, especially administratively, as we try to advance a solid and coherent and meaningful and safe recovery plan. Next. As far as equipment and PPE, we really did learn, unfortunately, from the misery of New York City. God bless them, it was terrible, but we were able to stay slightly ahead of that curve. I think we had our most difficult weeks around week 2 and 3 of April, but at no point were we under a absolute critical life-threatening restraint of personal protective equipment. And now we are fully equipped, and every patient who's in the hospital is equipped, as well as every person who works in the hospital gets a daily new surgical mask. For example, there's plenty of scrubs, hand sanitizer, the N95 respirators. All surgeons and nurses and everyone in the operating room has these. We can cleanse them for reuse. And then in terms of the issue of ventilators, we had enough because we got shipments in. We're offloading that, but here's what's happened with ventilators. We had to eliminate the acute care general surgery service in terms of providing emergency general surgery while our hospital continued to run. And we had to redeploy numerous surgeons who hadn't been doing that level of care in the past, who have been running it now for the past 2 months and still do. And so our ICU ACS attendings are needed to run the, sometimes at the peak upwards of 128 people on ventilators. And then finally, the supply chain. The supply chain has been shocked, and it will be continued to be shocked by this, not only because we don't know the inflow, we don't know the expiration in some cases, but truth be told, money and resources to resuscitate the supply chain are in massive question right now. Massive, massive question, as they are at most places, but certainly where I work. Next slide. In terms of equipment and PPE for recovery going forward, as I mentioned, patients, everyone needs a mask, whether they're inpatient or outpatient, and providers are all mandatory of having a mask, from food service personnel all the way up to CEO of the hospital. Everyone has eye and face protection, gowns, gloves, and surgical staffs at all of our operative sites have N95s. In terms of our equipment, we're hoping it's still there. I showed you the corridor. But I haven't used our intraoperative ultrasound machine in 2.5 months, so we'll have to look and find that. I'm sure it's around somewhere. But these are real, honest issues of practical limitation, and this just renders some sort of a scope of what's necessary to recover. Next slide. In terms of processes and protocols, I hope others will talk about COVID-19 testing. We're routinely using it for healthcare providers. I was thankfully tested on a flare-up in early April. It was made very easy for me. I felt very comfortable with it. Our patients are tested, and we will be having routine COVID testing going forward for any patients who do resume back into the elective surgical schedule. And in terms of infection control protocols, we have deep roles with contact tracing. We have some, as I've mentioned throughout my slides, lessons learned going back to Europe, Asia, but more importantly, New York City. And then now the whole concept of segmentation population modeling is being used as we build our reentry strategies based on milestones of anticipated elective volume and how to reach it, what the physical types of constraints in clinic and operating room and PACUs and ICUs would be necessary. We've been able to continue operating on people of medical and surgical need, cardiac disease, orthopedic surgery, multivisceral cancer, AHPBA cancers, et cetera, but not elective cases. And we have now a huge effort right now, and I think we're currently approaching for operative services a summary inventory of 3,000 operative cases that we're going to have to get back in the queue as we resume elective surgery. 3,000 cases that were bumped at the hospital over 6 weeks. Next slide. As far as the protocols, there's a few things I'd put here, and I'd hope folks will be able to get these slides to get these links made available to them. But the first is the Massachusetts Health Technology Consortium, which is working in our local community to put forth a statewide reentry, not only for the economy and business, but also healthcare. And it's based on these 3 key elements of segmentation, effective therapeutics, and reducing the rate of spread through contact tracing, through testing, et cetera. And then also, as we work, we've been looking at the American College of Surgeons guidelines, not only because they're great guidelines for surgeons, but they also reflect the efforts by anesthesiologists, nurses, and AHA. Last slide. And so I would just conclude again by thanking you. Be careful what you define as success. It may not be any of these 5 metrics. Probably your most important success will be able to shut down should the scourge of the virus come at a higher rate at your place. This thing does not obey any sort of metric. So I'd be very, very careful to think that this is over. And in the meantime, like you always do for the AHPBA, innovate, imagine, be flexible, patient, and finally, last slide. In a word, lead. Thanks, Tim.
Thank you very much, Dr. Callary. That was a fantastic presentation, and we know that, as you noted, that you up in Boston, as well as the Northeast Corridor, are bearing a large part of the brunt of this pandemic. So, we thank you. So I'd ask people to put their questions in the chat room, and we definitely want to ensure that folks who are on the webinar have a chance to ask some of our past presidents their questions, and I will be keeping an eye on the chat room, so please utilize it. So our next speaker is Dr. Reed Adams. Dr. Adams is a S. Hurt Watts Professor and Chair in the Department of Surgery at the University of Virginia Hospital. Dr. Adams was the president of the AHPBA from 2010 to 2011. And I think also very pertinent to our discussion tonight, Dr. Adams is also serving as the Chief Medical Officer of the UVA Health System, so has a very unique perspective, not only at the department level, but also at the health system wide level. Reed?
Welcome, everyone. Thank you for joining us this evening. Tim, thank you for the invitation. Mark covered a lot of things that will overlap with what I'm going to say and probably others. And so I'm going to try to move through these and hit on some of the things that might be a little bit different. And hopefully that'll open up some additional time for interactive discussion. So just to put it into context, we are not in the same position as Boston, New York. We do have a hotspot in the DC metropolitan area, so Northern Virginia is included in our statistics. But just to put it into context, we have about 27,000 diagnosed cases in Virginia. About 3,500 of those required hospitalizations, and we've had 927 deaths from COVID-related disease. So much different picture than what Mark shared with you in the Boston area. As a result, and because of our relatively different geography, so we are a substantial medical center in a relatively rural setting, we have not experienced locally the same degree of pandemic that others have. So again, Northern Virginia is a big hotspot for us. It's similar to Boston, less similar to New York, but that's where most of our cases are. And that's about 2 hours away. So we get some overflow from them, but we don't get a lot of primary cases from the Northern Virginia corridor. As a result, we typically have on the order of 30 to 35 COVID patients in the hospital at any one time. Having said that, at the beginning of this in early March, we, like everybody else, thought that we were going to be inundated. And so the entire operation shut down. And we went into essentially mass casualty sort of preparation. The hospital was essentially closed. We did nothing but tier 3 cases and a very few tier 2 cases on the surgical side, and the whole staffing plan changed. So we redeployed, I would say, the majority of our workforce, meaning all of our ambulatory care folks did retraining so that they could serve as acute care individuals, whether that's nursing, whether that's other type of staff, lab, et cetera. And what happened over about the 6-week period is the hospital was empty. So clinics were essentially shut down except for sort of tier 3, tier 2 kind of ambulatory care. ORs shut down by probably about 60 or 70%. In our ambulatory space, we were doing about 15% of what we normally do. And that took place over probably 6 or 7 weeks until we got to current state, which is what I think everybody's going to experience as our new normal. And for us, that means we're likely to have low-level COVID prevalence in the community for an undefined period of time. And that period of time is likely to be a year, year and a half, 2 years, all depending upon when vaccine and some sort of effective treatment is developed. So that has led to some of the things that I'll talk about on my slides as to where we are now and how we get back to what will be normal operations, but not normal compared to pre-COVID. So Tim had posed a couple of questions for us, and I'll go through those and just tell you what we've done locally, again, understanding that we're very different than Boston and major metropolitan areas. The other thing is the governor shut us down. So we had social distancing, all businesses, all non-essential businesses were closed. No elective cases could be done. And that included procedures as well as ambulatory care. And then in early May, either the 1st or the 4th, the governor came out and changed some of the rules. So still social distancing, essential businesses were all still closed, but we were then opened up to do elective cases and essentially elective medical care. And so that changed for us and everybody else in the state. And that's kind of where we are now, is trying to figure out how to get back to some level of normality. So in terms of cases, like Mark, we have about 2,000 cases that are backlog cases that were postponed as a result of shutting down and preparing for COVID. Now that we're open again, we're doing both elective as well as the urgent and emergent cases. We have opened both of our ambulatory as well as our inpatient operating rooms. And when the governor came out with the pronouncement that we were able to take care of patients again, our staff, physicians, the whole institution did an unbelievable job of turning our operations around on a dime. So essentially we went from about 20%, 15 to 20% in the ambulatory world, about 20 to 30% in the operative world. And over the course of a week, we're operating around 60 to 70% of our ambulatory volume compared to pre-COVID state. And we're probably 80% of our operative volume. Well, what that's allowed us to do is to take care of these backlog cases. We're trying to prioritize those. We have not had to use the Chicago prioritization system, but that's available if we need to adjudicate cases. And then we're also doing new cases as they come in. So we've been in a position where we've been able to ramp up pretty quickly to get those patients taken care of that had to be postponed. We did this in a variety of ways, but it required substantial operational changes. Mark addressed a little bit of that. We are all going to have to learn to operate differently. In the operating arena, block time changed, so we went away from block time to some extent. We've asked people to consolidate cases, so we extended the days, and we will do full day elective Saturdays if we need to, if it looks like we're not able to get caught up on our volume. But we've extended our typical OR days to take care of the typical volume, or to do more than our typical volume per day, and also to ask people to be flexible about their block time and being able to add on. We had a process in place where you could really only add on to your block time, so we changed. We use Epic as our EMR and changed it so that we have an open waiting room now. People can add their cases, and essentially they'll get added on as rooms become available. So we've asked all of our physicians to be flexible about cases getting added on and being available on relatively short notice to be able to do that. I talked a little bit about our expanded footprint in the OR, and then really this has required unbelievable cooperation from everybody involved: anesthesia, support services, nursing, and all of our surgeons. Next slide. So one of the other questions was, how did we manage the patients? As Tim said in his introduction, there was a lot of question as to whether people would come back. We thought that was going to be a major problem. It turns out not so much for us. People were eager to get their care. And that's evident, as I said, by the fact that we're operating at about 80% of our pre-COVID capacity in the main OR in our ambulatory OR. Part of the approach is the physicians and/or their care team reached out to the patients and talked to them specifically about what we were doing to protect them as well as our own workforce, and to offer them the opportunity to get their cases rescheduled, and also to talk through with them, what their concerns were. So a couple of things that we've done, similar to everybody else: universal masking for patients and staff. We fortunately just built a new tower that has a separate entrance, and so we were able to cohort all of our COVID patients in a physically separate part of the facility. So we're able to completely cohort those patients and not have a mixing of patients either traveling through the corridors to places or on a shared ward, for instance. So that allowed us to separate that population and allowed people to be comfortable that they weren't necessarily going to be mixed with patients that had or were exposed to COVID. So a lot of that was just boots on the ground, personal interactions with patients to try to answer their questions. Everybody was given talking points about what we were doing as an institution so that we could give a consistent message. And either patients really wanted to get cared for, or that worked, or some combination, because again, people voted with their feet and chose to come back and get their care. There was a question about determining elective cases. That was basically determined for us by the governor, opening up the state to do elective patient care. And that was really our trigger. Before that, we were doing tier 3, as I mentioned, and we were really doing a very small select case of tier 2, which you could argue were maybe on the cusp of tier 2, tier 3. We were probably overly restrictive. And then before the governor came out with opening elective cases, probably 2 weeks before that, we realized that we were not going to have the predicted peak that was predicted either by the University of Washington model or a variety of others, that at least for us, that peak kept moving. And so it was clear that we were going to be in this for the long haul. And then we talked about expanding our tier 2s. And ultimately, we internally had talked about a decision similar to what University of Chicago published, which was trying to understand what elective was versus patients that needed care. And if they waited longer than 4 weeks, 8 weeks, 12 weeks, then they would potentially be at some risk of harm. In terms of trainees, again, we don't have a high prevalence of COVID. So this has been a little bit less of an issue, but our residents, we went to a platoon system, probably like most places did, to protect our residents. So basically only a third of our residents were available in case people had to go on 2-week furloughs. And so we had enough of a workforce, at least while we were very low volume, to be able to do that. As we started ramping back up again, the residents are now back and we're operating again with a relatively full resident staff. Both before, when they were platooning, and now they participate in care of our COVID patients. Again, it's a pretty small number, so the risk of exposure is low, but when they do participate in it, both for our residents as well as others, we've put into place essentially telehealth instrumentation in all the rooms of our COVID patients. So basically a lot of that discussion can take place outside of the room. When they do need to physically see the patient, we've restricted it to 1 LIP, whether it's a learner or an attending, again, trying to minimize the number of people that need to be in contact with the patients to minimize exposure. And then the residents have also participated in the OR, again, with all the appropriate PPE. So they've been part of this process. And from a systems perspective, they were also involved in the design of a lot of how we were going to do this, both in the platooning, how we were going to protect ourselves. We have had a problem with PPE in the sense that we've had to be pretty proscriptive about it because we don't have an excess. The residents participated actively in developing protocols for how we're going to use our PPP and how we're going to preserve it. So it was a good learning experience for them, both in disaster management, but also in sort of operational management for the things that were pertinent to taking care of COVID patients. Next slide. PPE, as I mentioned, as Mark said, supply chain is still incredibly disrupted. So we've had to actively manage this. We were really at critical levels. We had about 6 days of N95s on hand the first 2 weeks. And after we put a bunch of controls into place, including centralization of the management, a distribution model for the different units, and really tight inventory control, we were able to manage that back up to about, at least at our current burn rate, somewhere around 100 to 120 days of N95s. That's really been the only thing that's been problematic for us. The other thing that's been problematic is swabs for testing, and I'll talk about that in a minute. The interesting thing about the PP management is we have the advantage of being a university with all of the different components of the university, all in the same area. So we've engaged our engineering folks, and they have been actively working on PPE production, as well as some other things that were COVID specific that allowed us to improve our care. Testing booths, for instance, working on N95 substitute mask, lots of 3D printing for different pieces of the PPE that we need. And so that's been a great collaboration with them, and they've really helped us out where we've been shy. The other thing that we did, and the residents helped design this, is went to a local inventory control management process. And what I mean by that is for instance, the cardiac surgeons or thoracic surgeons typically use N95s in the OR because of thoracic, entry into the lung, and then cardiac on their complex cases when they enter the lung parenchyma. So they developed an inventory management system. They get an aliquot of masks. It gets managed by the local team, and then the masks get returned for reprocessing, and then they get a new aliquot. And so that's really helped us manage our burn rate for our N95 masks. In terms of reuse, like a lot of places, we've been in the reprocessing business. We had UV very early on. That's an okay process, and more recently we've gone to hydrogen peroxide process to get more use out of our masks. Next slide. Testing is, as I think everybody knows, is a really contentious issue. We have the dubious honor of in Virginia of being sort of on the low testing side. A big part of that is access to testing. So UVA has been the state reference lab. We did in-house development, and we serve as one of the primary state testing sites. We do not only our own, but we do others. So we're screening in the incarcerated population, the nursing home population, doing point prevalence testing. And so we have to manage our testing supplies pretty tightly as well. And that has a number of implications, both locally and statewide. So in terms of trying to protect our workforce and our patients, and I think, Mark, you guys have this at Partners, we have a daily symptom reporting and attestation process. It's all web-based, it's an app. We do not routinely test our workforce. We do targeted testing based upon symptoms and our exposure. In terms of pre-procedural, so preoperative or other type of procedures, we do not do universal testing. Again, it's a targeted testing based upon what the data currently recommends, but also locally, the way that's executed is a screening tool that's either symptom-driven, exposure-driven, or congregate living-driven. So if you are in a jail or prison population, if you're in a nursing home population, any sort of group home, homeless shelter, that sort of thing, those all trigger testing before a procedure. We've set it up so that, again, operational changes, we've had to extend the time when our OR schedule's set from the day before to 3 days before. That allows us to do pre-procedural screening 72 hours before. And then if you screen positive, you get tested. If you screen negative, you don't need to be tested. And then testing can be done either locally or within an area close to home within within 48 hours of the procedure. And I'm happy to get into this in the Q&A if you want, but this is operationally really difficult to manage. So if you can imagine at our institution, if you universally tested everyone that's pre-procedural, that'd be about 250 people a day. So it's about 15 minutes to get somebody in and out of a swab situation to get tested. So if you do the math on that, that's about 100 hours of people time per day required just to do COVID testing. So you can imagine trying to operationalize that is pretty challenging. If you test positive, we postpone the case. If you test negative, then the case proceeds. The big unknown is if you test positive, no one really knows what the optimal management for those positive cases are. Do you wait 2 weeks and test? If they're negative, do you operate? If you wait 2 weeks and they're still positive, do you wait longer? We know from our own data, and I assume others as well that have been doing this, that you can remain PCR positive for out to 6 or 8 weeks after you're completely symptom free. So It's unclear if you still have a positive test and you're asymptomatic, what that means in terms of your infectivity. And then we are just rolling out a serologic test locally here tomorrow. The problem is that the role of serologic testing is completely unknown. Next slide. I think that might be my last, Tim. Yeah.
Great. Thank you so much, Reed. That was incredibly helpful to kind of hear your perspective on things. So our next speaker is Dr. Elijah Dixon, who's professor of surgery and oncology at the University of Calgary. Elijah was president from 2014 to 2015. And we especially wanted to hear Elijah's perspective, not only on the University of Calgary take on things, but also just the situation in Canada. Elijah.
Thanks, Tim. Thanks for the invitation, Tim, and it's nice to see all my friends. I will try to be brief, and I'll highlight some of the differences in the Canadian system and how things have evolved here in comparison to Reed and Mark. We've been fairly fortunate. Calgary's the biggest city in the province of Alberta, which is on the western side of the country. It's got about 4 million people in the province. Calgary has about 1.5 million people in it. And the whole city is run as a single health zone. So the Calgary zone, there's 4 adult hospitals and 1 children's hospital in Calgary. And they're all under the control of the Department of Surgery, University of Calgary. So Sean Grun is the department head, and I'm his deputy. There's about 400 surgeons in Calgary, and pretty much everything that's done in the zone is sort of done zonally. So policies and procedures are the same throughout the 4 adult hospitals and the children's hospital. The control and sort of the guidelines and recommendations come through a strategic clinical network, which is a provincial group, and it's made up largely of the leadership from the University of Calgary and the University of Alberta. Alberta is the other large city in the province. So in mid-March, when we started to see COVID cases, we very quickly shut pretty much everything down, and the only procedures that were being done were emergent and very urgent cases and cancer cases. The cancer cases were triaged into 3 categories of urgency: A, B, and C. A's and B's were the most urgent, and those, especially A's and B's, have been done throughout the entire time frame from early March right up until now. The big issue in Canada is that we usually work at around 95% hospital bed utilization. And so we're constantly sort of on the edge of not having enough inpatient capacity. So that was the big concern when this started, was that we had to really ramp down surgical activity to create space for the potential wave of patients that was coming. There was three models, a sort of mild, moderate, and severe models. And we expected that would peak at the end of April, beginning of May. And thankfully, we've been fortunate. Things have really flattened down. We have not seen the big wave that we were expecting. We've had about 6,500 COVID cases in the province. About 2/3 of those cases are in Calgary, and the other third largely in Edmonton. And we've had last time I checked earlier today, we had a total of 118 deaths. So we've been very fortunate. We've had most of our surgeons and surgeries stopped. I think the last time that I heard a number, we had over 10,000 cases that had been, we don't call them canceled, they've been postponed. So about 10,000 postponed cases. There's going to be a big backlog that we're going to have to start to work through quickly. Next slide, Tim. Tim had asked us to cover a few specific points. A lot of this has been covered by Reed and Mark, so I'm not going to go through it in detail. There was a lot of concern at the outset that we were not going to have enough PPE, and there was a lot of hand-wringing about how best to manage the PPE. Thankfully, that has not come to pass. There's been all the PPE that everyone needs, especially the N95 masks. There's a lot of concern about N95 masks and a lot of discussion about where those were to be used, what was the appropriate cases, especially the aerosol generating procedures. But we've thankfully had lots of PPE and have not run into any shortages anywhere. So we're in good shape for that. We continue to manage that carefully. Everyone in the institutions are wearing masks. Everyone is screened when they come in the front door. So when you come in the hospital, you have to either answer a set of questions or do it on an app before you get to work. And then everyone has their temperature taken before they come into the hospital every day. And that's at all 5 sites across the city. Next slide, Tim. So this is just a flow diagram for how patients are handled when they come through the operating room. I don't think that there's a lot of differences between other jurisdictions. They are streamed either into a COVID OR or a non-COVID OR. The number of ORs that were running at the beginning were about 1/3 of the ORs, so 2/3 were shut down. And we went from hospital inpatient utilization of about 95% to within about 2 weeks, we were down to 50 to 60%. So the hospital was emptied out of patients, and surgical volume was decreased really quickly and rapidly. All of the OR time has been managed centrally. So normally the OR time is given out to individual surgeons as blocks. When this occurred, that changed, and the site lead at each hospital, along with their dyad partner, the executive director, managed the lists of urgent and emergent cases centrally. So time was not given to any individual surgeon. It was given based on urgency to the patients, and that's continued up until now and continues now. So, you know, the lists for the OR are coming out a week in advance, and nothing really beyond that. Contacting the patients is generally done by the surgeon's office, and there's a script. So there's a script to use when the patients are contacted, so that we make sure that they all get the same information, and it's given in a similar format, and it's done by the surgeon's office. Often it's by the surgeon themselves calling the patients to discuss what's happened and what's going to happen. Next slide, Tim. So in terms of trainees, right at the outset, the medical school made a decision to take the medical students out of clinical care, clinical duties. The medical students were redeployed for 2 main things. They were doing contact tracing, so a big percentage of the medical students were doing that. And then the other was all the schools were canceled in the province, and so many of the healthcare workers had children and young children at home, and didn't have childcare available to them. And so a lot of the medical students actually volunteered to help out with childcare for the healthcare workers. So the medical students were involved in looking after the healthcare workers' kids and contact tracing, and that's continued up until now. Things have, it looks like we're not going to get the big wave that we expected, and so we're just now starting to get back into relaunching and doing more in terms of the OR, and in terms of the services becoming active again. The different surgical services were functioning basically in a what we would see in a holiday mode. So the call schedules were covered, but the services were manned with a skeleton staff, And that's now changing. So all the residents and fellows are coming back and getting more involved. Many of them were redeployed to other areas, including ICU, but the demand and need there has not developed as was expected, which is good. So they're coming back to the Department of Surgery, and those services are going to start to ramp up again. Next slide. So basically the only surgery that was done was urgent, emergent, and cancer cases, and the more urgent cancers, the A's and B's. There's still a bit of concern about bed capacity. So last week we started doing day surgery cases, and so those have been triaged, and the postponed cases are going first, and then there's a urgency sort of triage system for the other day surgery cases, and the OR has ramped up quite quickly, and we've gone from where we were running about a third of the rooms to well over 50%, and then depending on the hospital, up around 75%, but with just day surgery cases right now, so that it doesn't have a big impact on bed capacity. And you can see here on this is sort of the rough outline of what's going to happen. They're going to start to allow overnight stay cases probably next week, depending on what the bed capacity looks like and how many COVID patients are in the hospital and in the ICU. But I would expect for late this month, we'll be doing urgent 14 to 28 day cases. Those are sort of, mid-range urgent cases. And then in June, if again, capacity issues are looking reasonable and there's not a huge surge in terms of COVID patients, that we'll start to do elective cases again. These are still being all managed centrally at each site by the site lead of surgery. And that'll probably continue well into June. And I think that potentially in July and August, we might start going back to block time given out to surgeons on an individual basis. But up until then, the cases are not assigned based on surgeon time, but based on the cases and patient urgency. Next slide. I think that might be the last slide. Yep. So I'm happy to answer any questions at the end. Thanks, Tim.
Thank you so much, Elijah. Really appreciate you sharing your experience with us. So our next speaker is Dr. Rebecca Minter, who's the A.R. Curry Professor and Chair of the Department of Surgery at the University of Wisconsin. Dr. Minter was president of the AHPBA from 2017 to 2018. Rebecca.
Thanks so much, Tim, and thanks to the prior speakers. It's been great to learn from everyone through this whole process. I think that one of the things that we've all learned through this has been how difficult it is to lead in such an uncertain time. And I have reached out to my friends and colleagues on a daily basis, and they've been extraordinarily helpful. Up until a couple weeks ago, this is what Madison has looked like in the picture here, with really in Madison and South Central Wisconsin, people really, there's a large German population in this area. People were very good at following rules, and everybody stayed home when they were told to. And this is really what the streets looked like. People now are starting to emerge as the sun comes, and we did get snow on Sunday for Mother's Day. But it really, the social distancing for us really was taken very seriously and had a very positive impact. Next slide. Next slide. I thought I might take a slightly different tack in terms of talking, last slide. I think there's a delay. Just talk about kind of what this has felt like, I think, for all of us as we've moved through this. And I think particularly when Tim asked, thinking about the AHPBA, as you'll recall, for those of us who were at the meeting, that's really when things hit. And I remember very keenly that we were all very much in that left upper quadrant box of complete denial. I can't remember how many conversations we had poo-pooing the, what do you mean I'm not going to shake hands? What do you mean I'm not going to kiss you on both cheeks? The measles kill way more people than this. This is complete overreaction and ridiculousness. And I think, really even over just the course of a couple of days, as we saw our institutions and colleagues not able to come and things really shutting down, quickly then moved into this this kind of bottom box when we were then told, you can't travel, you have to stay home, all the sort of restrictions on what we perceived as our liberties, and then really kind of that negotiation phase. Then had to really very quickly get into this kind of commitment to, oh my God, this is real. And this entire cycle, which normally takes a really long time, happened, really truly over the course of about a week for all of us, especially those of us who had to lead our department. Next slide. And so I think early on, we all quickly moved into this planning phase, and we spent huge amounts of energy. And, I think the commitment, we would all say this of our teams, that we've seen across the board has really been truly inspiring. And at this point, there was a lot of fear because we didn't know how to plan for a pandemic. We'd never done this before. We ultimately had a lot of clarity of purpose in terms of what we were planning for. Next slide. And so while it was a scary time, it was very tactical. It was very purposeful. These are all the steps that we all went through and that I think have been highlighted by my colleagues in the prior talks. And it was a tremendous amount of work. And again, we were all fearful as we prepared and took care of patients with COVID. But there were kind of these series of steps that we followed. Next slide. And I think that one of the things that proved incredibly useful in my department and my institution is that we had just finished a strategic planning process over the last 2 years, and I had my leadership team read this book, Team of Teams. And if you have not read it, I cannot recommend it highly enough. It's written by General Stanley McChrystal, who was a leader in Afghanistan when we were fighting Al-Qaeda. And he really, I think, laid out a framework for leadership that could not be more relevant than where we are today. Next slide. And what General McChrystal talks about is that, basically, despite the fact that we had tremendously more resources, expertise, ability than the enemy, in the early days in the Middle East, we were basically getting our butts kicked. And the reason was because the military looked very much like an academic medical center, which was very hierarchical, very up and down. You had, your CEO and the dean at the top, and then you have your departments, and then you have your divisions, and decisions kind of have to flow up and down through all of those pathways. It's a very non-agile approach to leadership. And so he really talks about how they had to move through this series of steps to realize that they really needed to shift from that hierarchical up and down model, first to a command of teams where there was sort of clarity of purpose at the top, and then that clarity and goals were executed through individual teams. But even that didn't really work because the enemy, Al-Qaeda, was incredibly loosely organized. And as soon as they stood up one initiative, they would just pivot and go a different way. And so I think it actually is a great parallel for what we were dealing with COVID. We would have a plan and then there wouldn't be PPE. We'd have a plan and then we wouldn't have reagent for testing. We'd have a plan and then we didn't have enough, negative pressure facilities to pick it. But we didn't really know what we were dealing with, and it kept changing. It was a very fluid environment. And so we had to quickly pivot out of our hierarchical organizational structure and really try to get to this team of teams approach where the hierarchy was flattened, where we were all working across departments, really interdependently. And we had to do that very, very quickly. Next slide. And I think importantly, what he talks about in the book is that to have that team of teams approach work, you have to have a collective consciousness. Everybody has to understand with absolute precision what the mission is that everybody's working towards, because you might have to, again, pivot or figure out how to do something differently. As long as you, again, had clarity of purpose and mission, you could do that and everybody would stay aligned in that sort of chaotic seeming team of teams. So initially in the department, our progressive planning mission, if you will, and with our health system, was to be able to provide remarkable urgent health care and critical care to all who needed it. And this meant not just to our COVID patients, but any patients who might show up with a ruptured aneurysm, with a cold leg, with pancreatic cancer, with hilar cholangiocarcinoma. We needed to be able to manage all of those patients who had those conditions that really also required very timely care, not just emergent, but also what I would consider urgent healthcare issues. Next slide. So this was really our team of teams then that we constructed, and you know, we all had kind of the Hicks model incident command at the center, but we really stood up these other teams, and they were all, again, quite interdependent. Our surgical and procedural services group, really responsible for our OR and procedural services. We were doing anesthesia. We do test every patient. Early on, we made that commitment to testing any patient having an aerosolizing procedure. We've expanded that further. We're fortunate, our OR team did a great job. We have a drive-through testing center, so the schedulers, once the patient is scheduled for surgery, and I'll talk about how we did that in just a moment, they would be given an appointment time. Within 48 hours of surgery, they drive through, get their test. So that really was stood up very quickly and quite seamlessly, and that was a project with our ambulatory team and the OR team. Critical care operations stood up across we collapsed all of our ICU services together across 4 different departments. Acute hospital medicine obviously was critical in this, and this really put together our whole surge plan. We also created these strike teams to do airways, to do lines, so that you could have a less experienced team filling in these areas and not have to do those procedures, and also to make sure that it was safe, airway being the most dangerous. So that was sort of our team of teams approach. And really, I would say, even though as we've moved out of progressive planning now into where we are right now, this structure is still there in the background. All of those schedules are in place so that we can quickly pivot if we need to. Next slide. Much like Elijah, you know, we've been very fortunate that we never really got the huge surge. So early on, there was quite a steep curve in Wisconsin. The rest of Wisconsin doesn't look quite like South Central Wisconsin and Dane County has. There have been certainly hot pockets, particularly in Milwaukee, Green Bay, related to some meatpacking plants and other areas. But in Dane County and our surrounding area, it's been quite flat. So we then pivoted out of what we call progressive planning into, next slide please, our essential services planning, and again needed a collective consciousness for how we were going to move forward. And so we really pivoted then to a mission of providing all essential health care, is what we called it, to patients in a safe and responsive healthcare environment. And that gets to being certain that we're doing social distancing, that we're doing all the testing and things that folks talked about on entry to our facility, being prepared to pivot if we have a surge. We had a hospital in Rockford that had several skilled nursing facilities with outbreaks, and so went into a period where we thought we might be receiving those patients last week. And so really being able to pivot back and forth, again, very agile is what we've had to be, to go back and forth between our progressive plan and our essential planning going forward. Next slide. Specific, and I love Michelle Obama. I put this in here to remind me, this part is so much harder right now, I think, than the progressive planning from a leadership standpoint. There's so much ambiguity, so many more unknowns, and it's not so linear in terms of planning for surge, in terms of the sequential steps. So I think, you know, as others have commented before me, you know, this phase of planning and what's ahead, particularly because of the economic impact and the furloughing and compensation cuts and everything we've had to do, I think is a lot harder. And people are also tired now. So people are in a different sort of state of mind than they were when we were doing surge planning. Next slide. So just to cause confusion, you know, we immediately, when we had to stand down surgery department, I came up with these tiers so that we could tier all of our cases. This was before we had the CMS tiers. They actually aligned reasonably well, but we tiered all of our cases based on these priorities. And I really left this, we didn't try to put rigid rules around this other than making it clear that, you know, urgent cases were those that needed, obviously emergent cases need to be done right away, but kind of urgent cases that needed to be done in less than 2 weeks. you know, there's no black and white for this, and we made it clear what the expectations were for surgeons. I delegated authority to my division chairs to make decisions about inappropriate decisions, but people really made good choices, especially during this time. And so these were kind of how we outlined our cases. And I think that it was important to leave this to the individual surgeons to do and then roll it up through the divisions to make sure we're making consistent decisions across cases, because not every patient is the same, and you can't base, you know, a patient with horrible biliary colic who can't eat, I think, you know, has some urgency and needs to get done. You can't say we're not doing any gallbladders. So I think this was how we did it. We built this then into Epic, so we could tag all of our cases, and we ultimately had about 2,000 cases in backlog as well. This created reporting functionality for us in Epic, and we will tier cases forever forward going forward in the event that we're ever in this situation again, so we never have to go backwards. This created the ability to have fantastic reporting functionality out of Epic. Next slide. So then in phase one of this, I think similar to what Elijah was describing, we had no block time. We operated 6 days a week, 11-hour days. We would have 48 to 72 hours notice of the schedule. This was hard. And I will tell you that for all the clamoring before COVID that people wanted ORs on Saturdays, nobody wants to operate on Saturday. And so what we learned through this after about 2 to 3 weeks of Saturday ORs is we stopped them. People were very happy to have longer days. It was very hard to fill the Saturday OR time, and it led us to have a lot of challenges with our nursing staff in terms of staffing the ORs when then there wasn't work to do. Next. Phase two is really where we are now, and I think we actually probably won't ever go back. So we also had individual surgeon block time, which is different than what I was used to at prior institutions. It's not the most efficient way to have block time. So we now have allocated service block time based on pre-COVID actual utilization in terms of minutes and days. It allowed us to hold back more shared time, to be more flexible, to add those cases on, operating Monday through Friday, extended hours, and trying to have people have their usual days as much as possible, but that flexibility that others have talked about is a critical must. We have worked through our tier 2 cases now and are starting to work on tier 3. Next slide. So here's kind of where we are so far, and we had a more gradual than what Reed described. We had an immediate drop as well, but we've had a more gradual increase over the last 3 weeks, up to 74% of our procedural volumes. These are the out of the OR volumes. Next slide. And looks very similar for our OR cases, where we're at 73% of our pre-COVID volumes. We anticipate next week being up to 80%, and then we'll have to sit, I think, there and wait and see, because of the issues that Tim outlined at the very beginning, where some patients just aren't quite ready to come in for things that really are elective. And so we're trying to staff responsibly. We also have folks on furlough. We're trying to be very frugal with those resources as well. So we are anticipating that's probably where we'll sit for a little while, because we're not bringing in cosmetic surgery and things of that nature. Next slide. I think this is what keeps me up at night worrying. This is kind of showing what's happened with our ambulatory visits. Though this week, fortunately, we're up to 65%. Is that this is going to be the next dip for us? You know, we're getting through our backlog. We expect by the second week in June, we'll have actually caught up on all of our cases. Our ORs have been running with very high efficiency and utilization at all of our different hospital sites. But surgeons need a pipeline. And, you know, all of the primary care, screening mammography, screening colonoscopy, CT angiogram, all cath lab, all of those things shut down for 2 months. And now we need those patients to get back in the queue, be seen, get referred, et cetera. So my worry is what's coming later this summer is a potential second dip until we get the visits back online and we get testing back online. Radiology in particular has been something we've really been pushing hard for, because as we all know, if we don't have access to imaging, we will not have access to cases. Next slide. And this relates to the economic impact. I think most of these things have been touched upon. I would say that the one thing that hasn't, that I'd like to emphasize too, is that as we've stood up our tiering system in HealthLink, we've had that directly linked to our rev cycle operations, which has been really key and important too, because you might think, oh, all these cases had prior authorization before COVID. Well, many people have lost their insurance, and many people who have high copays are no longer in a position to pay them. And so it's very important that every case goes through prior authorization again, so that patients don't have financial liability that they're not prepared for. So I think this is the other piece, the other reason why we're sort of anticipating we're likely to sit at 80% rather than 100% for a little while, is that there are also patients who aren't able, unfortunately, to access healthcare, and we're going to have to all deal with that as well. I think there's been tremendous opportunity to innovate in this time, and we're trying to leverage those opportunities. As I said, we're not planning to go back to our pre-COVID OR operations exactly. So with that, I'll turn things over to Felipe.
Thank you so much, Dr. Minter. Really appreciate it.
Oh.
So our last
those slides were supposed to be deleted. You can
no
just
problem. So our last speaker is Dr. Felipe Coimbra. Felipe is the chief of the Department of Abdominal Surgery and Surgical Oncology and chair of the Division of Gastrointestinal Oncology at AC Camargo Cancer Center in São Paulo, Brazil. Felipe was the president from 2019 to 2020. So Felipe, thank you so much.
Thank you, Tim. Thank you, AHPBA, and good evening, everyone. It was nice to hear from you, and it's very nice to learn from each other here. So first of all, I'd like to show you some perspective we have here in South America and Latin America. So this in the right here are the four most affected countries in South America. So Brazil, Peru, Chile, and Ecuador are the most affected countries. If you compare with USA, Canada, Mexico, and Dominican Republic, you can see that maybe, at least comparing to USA, the number is not so high. But for example, in Brazil, you have almost 107,000 affected patients. You should not underestimate this, because we have to consider that most of the patients probably have not been tested so far. So the numbers would be much higher. The next one, please. So regarding the mortality, again, Ecuador, Peru, and Brazil, and Chile are the most affected countries. And if you consider mortality for 1 million people, you see that Ecuador, Peru, and Brazil have a very high number, but not so high as, for example, in North America so far. The next one, please. So just for you to have in mind what's happening and what institution we are, and one thing that's very important too is that maybe we don't really represent everything that's happening in South America, because we are in a big city, in a big hospital too. So we are in São Paulo, which is a 12 million people city, the largest in South America. Our institution is a specialist hospital in Brazil, so we have around 500 beds and around 700 physicians. We are a cancer center, so we have only patients who treat cancer, or we may treat some benign disease from those patients who have treated cancer in our institution. So our hospital situation regarding the COVID, we are in a phase 1, which means that we do have patients with COVID-19 in the hospital. So far, we had already 109 positive patients. Among those, 31 recovered. These are only patients who treated here already. We don't have an emergency department, an open emergency department. So patients with COVID come only if they are treating cancer in our institution. So, and we also have a specific COVID ward in ICU since the beginning of the pandemic. And regarding the phase 1, which it means is that even though we have these patients, the resources, ICU beds, ventilators are not a threat so far. Regarding the PPE level, so everyone who enters in the institution should use a surgical mask since April. Regarding PPE level in the surgical rooms, we have all the usual vestment, goggles, the N19 masks, respirators. We have been using it for all surgeries. Doesn't matter if it's open or if it's laparoscopic or robotic, because we understand, especially for our surgeries such as liver and some others, we have a lot of smoke, which, even though they are not minimally invasive, they may increase the risk of contamination of the OR environment. So we are using all these protections. An important point regarding intubation, as I think we have discussed in the last meeting too, we all go out of the room and only the anesthetist and the assistants intubate, prepare and intubate and the anesthesia for the patient, and we come back 15-20 minutes later. And for the laparoscopic and the robotic, we've been using a filter in the suction system. So whenever we take out the gas inside the abdomen, so it goes through the suction system with a filter in between. The next one, please. So just for you to have a perspective of the timeline that we have here in Brazil so far. So we have here in March 16th, the pandemic declaration. And then the first 1-2 weeks, we were first evaluating what was happening all around the world and understanding from each. And at this moment, we keep doing elective surgery. Clinics and elective surgery were stopped. We were paralyzed. And then we started having the social distancing in São Paulo and in Brazil. Most of our surgeries were postponed. Then we started thinking on how to prepare some patients for surgery because we didn't stop completely. So we started doing preoperative testing selective only for complex surgeries, besides a questionnaire before surgery, and the PCR before surgery for only a big surgery, which included our AHPBA ones. Then we are now discussing the reemerging of our AHPBA surgeries here and in general in the hospital. So we have created this idea of having a protective pathway for cancer patients. And in the next slide, please, I'm going to explain a little bit more about this. So this reemerging, which was one of the most important topics for discussion, I think, we built this protected pathway for cancer and chronic diseases patients. So at the hospital entrances, they apply a questionnaire, temperature measuring. They give patients use a surgical mask. We are not allowing visitors or chaperones anymore, only for very selectively for elderly or physical limited patients. And we have been testing since 2 weeks ago all patients with and we have been using a thoracic CT before surgery. So for all surgical patients, they have been testing for at least 72 hours before the surgery. And we have also been using thoracic CT the day before the surgery for upper GI, which includes AHPBA in our department, and also for cardiothoracic surgeries. The reason for that is that we know that the PCR tests have a sensitivity of only 30% for asymptomatic patients. And there is some data showing that for asymptomatic proven COVID patients, thoracic CT may have a sensitivity of around 55%. So in order to increase the safety for these patients and for the team, we have decided to do this for our surgeries. There are already some guidelines considering CT scan, thoracic CT scan before upper GI HPB surgeries and thoracic ones already. Just for you to have an idea, from about 300 patients tested for these last 2 weeks, we have around 10% positivity. So what we have been doing is postponing another test, the surgery, and doing another test in about 2 weeks. And if they are negative, then we go for surgery. And this is very important because we have a study, for example, in Brazil, that about 50,000 cases of cancer have not been treated since the start of the pandemic. So this is a very important topic because I believe that later on we will expect a cancer wave, a cancer peak, and chronic disease mortality increase because they are not having the chance to come for treatment, diagnosis, and follow up. So that's why we believe this is very important to give this opportunity for these patients to come back for treatment in a safe environment. So our institution also started doing some social awareness campaigns for those patients who are symptomatic, for those who have not diagnosed the cancers, or for those who have stopped the treatment. So I think this is a very important thing we should do even as an association maybe. And what will follow then after this? So we expect that we have a workflow here. So patients are not diagnosing, they are not staging, so they're not treating. So I think there will be a long way until you have some return in about maybe 78%, as Rebecca said, of these patients coming back for treatment. And then we will maybe have an increase in the surgical new cases. And that's when we're going to start also on the postponed cases. So we have to learn how to prioritize it. We don't have these worries now because we have a lot of room in our hospital. Remember that we are a specialty hospital. So patients with COVID from the community don't come to our hospital. So we have a lot of room, and we creating then this protected pathway for these patients. So we expect not having problems with the re-emerging of these patients to our institution. So of course, we're going to start, if necessary, with less comorbid ones, younger, with more aggressive tumors. And on the second moment, with more complex, older, or with patients with much more comorbidities that may have to wait a little bit for these situations. So about residents and fellows, we have decided to ask some of them to not coming, and they do like a turn in our institution per week. So we have around 1/3 of our fellows coming. They all keep coming into the surgery, one for surgery. And what we have been doing is in order to keep them linked and together with us, is to increment the educational part of the program and also include them in some research programs that some were participating. So the next one, the last one. And so to finish, I think I agree with you all that I think this will be the new normal. We have to learn how to deal with this. We're postponing patients for 1 month or 2. It has already passed this time, and we are now asking these patients to come back so they don't have, they won't lose the chance for treatment and cure. So with this, I end, and I think, Tim, if there's some time, can open for discussion. Thank you.
Thank you so much, Felipe. I appreciate it. So given the hour, I want to be respectful to folks' time. We will forego any discussion at this point. However, I would ask that any of you who have questions for either myself or any of my speakers, please either email myself, Margie, or Jill, and we will be sure to communicate with you via email with the pertinent follow-up. I would really like to take the opportunity to once again thank our esteemed list of speakers today, our past presidents, Dr. Callery, Adams, Dixon, Minter, and Coimbra, for doing a wonderful job sharing with us your experience in your respective medical centers. I want to thank all of the members of the AHPBA for participating and listening in on the webinar tonight. Thank you for all that you do. And in particular, thank you for the great care that you deliver to all of our patients who are suffering from HPV diseases. With that, I wish you all well. Please be safe. And thank you very much for joining us tonight. Thank you.
Thank you.
Thank you very